So our lab is the Pulmonary Optical Imaging Lab that's in the pulmonary unit on the MGH main campus, but it also has close ties to the Wellman Center for Photomedicine. And our work is primarily focused on the use of optical frequency domain imaging for studying airway diseases, including asthma, lung cancer, COPD. We're looking at lung transplant. But the talk today is going to be on lung cancer. So why we're doing this is because it's the leading cause of cancer-related death, and early diagnosis is critical to patient survival, but the early diagnosis doesn't happen right now, so the current 5-year survival rate is under 15%. And the reason for this, or part of this reason, is that it's often hampered, the diagnosis of lung cancer is often hampered by the low diagnostic yield of low-risk bronchial biopsy due to the very small sizes of tissue sampling that can be taken through these non-invasive sort of techniques or minimally invasive techniques. And so we're looking again at using optical frequency domain imaging to increase diagnostic yield and also to potentially do in vivo diagnosis. I think we pretty much all know what OFDI is a second generation version of OCT. So what it allows us to do is image at a significantly higher frame rate. And so then when we couple that with the appropriate catheter designs, we can do comprehensive microscopy in vivo. So the approach that we're taking, this research is very multidisciplinary with lots of collaborations. We're working with physicists and optical and biomedical engineers to work on the imaging systems and the catheters, pathologists and pulmonary physicians to develop the OFDI diagnostic criteria, and then also with thoracic surgeons and pulmonologists again to actually do our in vivo studies. So it's very a large group all working together. So briefly, our OCT imaging systems, this is an example of some of our catheters here. It's a unique challenge in imaging the airway because of the structure of it, the branching structure of it. You start with large airways, you go to small airways, and then you have to image the peripheral lungs. So we're developing catheters for imaging the airways as well as for these needle probe catheters that allow us to image beyond the airways and into the peripheral lung. This is just some of our example of the images that we're getting working with pathologists to develop these diagnostic criteria. I've got an example of peripheral airway imaging, peripheral lung imaging up here where it's a case of cancer, of the alveolar cancer. If this were normal, you would see nice, clear delineation of alveolar structures, but instead you see mucin-filled alveolar structures that have increased walls. And there's two examples of airway cancers where we have here a tracheal adenocystic carcinoma where we see this protruding mass in the lumen and pseudocystic filled spaces. This is what a normal airway should look like. And then we have a case of squamous cell cancer also in the airway here. And so what we're learning from this ex vivo imaging, we're using that diagnostic criteria to help us interpret our in vivo images. And these are some examples of normal and of squamous cell cancer that we've taken from patients in vivo. So our research is really limited by the target selection from external imaging modalities such as CT. So our wish list is potentially to increase the sensitivity or the selectivity of these target site selections and potentially to also extend beyond just the structural imaging to increase some sort of molecular imaging or other functional imaging capabilities. And so that's our contact information. Thank you.
Very good. Thanks so much.